Good afternoon. This hearing will come to order. I want to welcome everyone to today's legislative hearing on H.R. 1490, the Veterans Privacy Act, H.R. 1792, the Infectious Disease Reporting Act, and H.R. 1804, the Foreign Travel Accountability Act. The three bills we will consider today are the result of investigations conducted by this subcommittee in the course of its oversight duties that have reported poor judgment and mismanagement by the Department of Veterans Affairs. These bills are intended to heighten the protections for our veterans at VA medical centers and prevent the recurrence of problems identified in the investigations. H.R. 1490, the Veterans Privacy Act, was introduced by the chairman of the full committee, Representative Jeff Miller. The bill directs the Secretary of Veterans Affairs to prescribe regulations to ensure that in the absence of informed consent by the patient or their legal representative, and any visual recording can only be conducted under limited circumstances, such as under court order. In April, I introduced H.R. 1792, the Infectious Disease Reporting Act. Based on investigations conducted by this subcommittee, as well as a hearing in February, it is clear that VA needs to be held to the same standard for infectious disease reporting as its healthcare counterparts in each state. The Infectious Disease Reporting Act will require VA facilities nationwide to comply with state infectious disease reporting requirements. Once reported to the state, this data will be reported to the Centers for Disease Control and Prevention and used to monitor public health. Each state faces its own unique challenges regarding infectious diseases, and the Infectious Disease Reporting Act takes this into account. It is baffling to me that the University of Pittsburgh Medical Center Hospital, which sits just a few hundred feet from the Pittsburgh VA Medical Center, is required to report infectious diseases, while the VA hospital is not. The news reports from Pittsburgh this last weekend detailing the extent of the Legionella problem and that it dates as far back as 2007 underscore the need for this legislation. The fact that VA provided information to reporters that this subcommittee has been requesting since January is unacceptable. This lack of transparency looks like an attempt to evade legislative oversight and makes me wonder whether there is more to this story than what VA has chosen to reveal. The need for the Infectious Disease Reporting Act is reflected not just in the Legionella's disease outbreak in Pittsburgh. Just last month, almost 20 veterans tested positive for hepatitis A or B after a VA hospital in Buffalo admitted to reusing insulin pens on patients. Time and again, we have heard from VA that they are industry leaders in various areas, but infectious disease reporting, VA doesn't even compete. Our final bill today is H.R. 1804, the Foreign Travel Accountability Act, which was introduced by Congressman Tim Holzkamp, a member of this subcommittee. This bill directs the Secretary to submit to Congress semi-annual reports on foreign travel. The reports will include, among other things, the purpose of each trip, the destination, and the total cost to the Department. In January, after VA told him the State Department may have records on VA foreign travel, Chairman Miller sent a request to the State Department for more information. Just last week, he received the State Department's two-sentence reply, which referred him back to VA. This ridiculous finger-pointing clearly exhibits the need for this legislation. It is important that taxpayer dollars appropriated to VA are properly spent on providing the care and benefits our veterans have earned, not sending VA employees abroad on taxpayer-subsidized vacations that do little to improve the care veterans receive. I appreciate everyone's participation in today's hearing and now yield to the ranking member for her opening statement.
Thank you, Mr. Chairman. Today we meet to hear testimony on H.R. 1490, Veterans Privacy Act, H.R. 1792, the Infectious Disease Reporting Act, and H.R. 1804, the Foreign Travel Accountability Act. H.R. 1490 seeks to ensure that any visual recording made in a VA healthcare facility is done so with the express permission of the veteran. H.R. 1782 requires the VA to report any instance of infectious disease within medical facilities to the appropriate state entity. And the third bill, H.R. 1804, requires that foreign travel of VA employees on official business be reported to Congress. As the Subcommittee on Oversight and Investigations, it is our primary duty to provide oversight of all VA programs and facilities to ensure they are run effectively, efficiently, and lawfully. Our mutual goal is to deliver the best possible services and protect eligible veterans and their dependents when they are in VA facilities receiving services. It is my hope through the oversight process not only to point out weaknesses in areas needing attention, but also to back the VA up in its mission to care for veterans. As times change and new challenges arise, we must work hard to provide VA with the tools it needs to be successful and meet those challenges. I look forward to the witness testimony today to examine how the changes embodied in each of the bills can help veterans. I thank the witnesses for being here and for answering our questions, and I thank the others who are here today for your interest. I yield back, Mr. Chairman.
Thank you, Ranking Member Kirkpatrick. We will now hear from our first panel of witnesses. At the dais, I'm honored to have our Chairman, Jeff Miller, to discuss H.R. 1490, the Veterans Privacy Act. Next, we will hear from the Honorable Tim Hulskamp from Kansas, who will also be speaking from the dais, who is sponsoring H.R. 1804. Thank you both for joining us here today. Your complete written statements will be made part of the hearing record. Chairman Miller, you are now recognized for 5 minutes.
Thank you very much, Mr. Chairman. Members, it's a pleasure to be here with you again, and you may know some of the details of what I'm about to tell you, but others you may not. Last June, a video camera disguised as a smoke detector was installed in the room of a brain-damaged veteran at the James Haley VA Medical Center in Tampa. When the veteran's family discovered the camera, they were understandably upset. When asked about the camera, VA officials first denied that the camera existed. Then they, in fact, admitted that the smoke detector was, in fact, a camera. Further, when asked if the camera was recording, VA said no, it was only there to monitor the patient. And only after inquiries by the media and this committee did VA come clean and admit that the camera was, in fact, recording what was going on in the patient's room. Ultimately, VA yielded to the pressure and removed the camera. When I learned about these events, needless to say, I was shocked at VA's apparent disregard for the privacy rights of its veteran patients. VA failed to provide any justification for covertly recording this patient in his private room. In light of this incident, I asked VA under what legal authority did they place the camera in the patient's room. And VA's legal opinion was that the hidden camera did not, in fact, violate law, and that they were looking at developing a national policy to address the issue of video surveillance of its patients. I have recently been told by VA that they do not intend to have this policy in place before September 2013. This is a year after, well over a year after I found out that the incident actually occurred. So in order to protect the privacy rights of veterans who receive medical care from VA hospitals, I have introduced what I call the Veterans Privacy Act. This bill directs the VA to prescribe regulations to ensure that any visual recording made of a patient during the course of their care by VA is carried out only with the full and informed consent of the patient or, when appropriate, that patient's representative. Now, the bill does contain some important exceptions. The Secretary would be authorized to waive notice and consent for recordings. Upon determination by a physician or a psychologist that the recording is medically necessary, or pursuant to a court order, or when the recording would occur in a public setting where a person would not have a reasonable expectation of privacy, such as in a waiting room or in a hallway. I look forward to working with committee members, our Veteran Service Organization partners, the VA, and other stakeholders on this bill, because protecting the privacy rights of patients while they're receiving care in VA must be among one of our constant priorities. I appreciate Chairman Kaufman for holding this hearing today. Your hard work and leadership on the subcommittee of Oversight and Investigation is greatly appreciated by me, the ranking member, and other members of this committee, and I appreciate the opportunity to be here with all of you today, and I yield back my time.
Chairman Miller, thank you so much for your testimony. Congressman Hulskamp, you're recognized for 5 minutes.
Thank you, Mr. Chairman. It's a pleasure to be here with you today and the other members of our subcommittee on oversight investigations. I also appreciate our representatives from our VSO partners and other interested stakeholders to discuss H.R. 1804, the Foreign Travel Accountability Act. The bill is very simple and very straightforward and would direct the Secretary of the VA to submit to the House and Senate Veterans Affairs Committees a semi-annual report on all foreign travel made during the previous 180-day period. Each report will be required to include the purpose of the travel, destination, name and title of each employee traveling, along with the duration and the total cost, including transportation, lodging, and a multitude of other associated costs. I believe providing Congress information about foreign travel by VA employees is not an unreasonable requirement. In fact, I think receipt of this information is critical to making certain we do our job properly here, Mr. Chairman, and providing proper oversight of the VA's expenditure of taxpayer dollars. I look forward to working hand in hand with other committee members, our VSO partners, and other stakeholders, including the department, on this bill as it is discussed this afternoon. I take our responsibility of oversight very seriously as stewards of not only of taxpayer dollars, but as stewards and advocates for veterans. I think this is a very critical bill. And again, thank you for holding this hearing. I look forward to any questions you might have. And with that, I yield back.
Thank you, Mr. Hulskamp. Without objection, in the interest of time, there are no questions for the first panel. Any members wishing to ask questions of the first panel may submit them for the record. Without objection, so ordered. On behalf of the subcommittee, I thank you for both for your testimony. You are now excused, except for Mr. Hulskamp. I now invite our second panel to the witness table. First, we will hear from Dr. Robert L. Jesse, Principal Director Undersecretary for Health for the Department of Veterans Affairs. Accompanying Dr. Jesse is Ms. Jane Claire Joyner, Deputy Assistant General Counsel for the Department of Veterans Affairs. Dr. Jesse, your complete written statement will be made part of the hearing record, and you are now recognized for 5 minutes.
Thank you, sir. Good afternoon, Chairman Kaufman, Ranking Member Kirkpatrick, and members of the subcommittee, and Chairman Miller. I'm pleased to provide the department's views on each of the bills on today's agenda. Thank you for the opportunity to do so, and as you mentioned today, joining me is Deputy Assistant General Counsel Jane Claire Joyner. Chairman Kaufman, we do appreciate your continued efforts and those of this subcommittee to support and improve veterans' health care. VA recognizes the importance of addressing the underlying issues related to each of these bills and looks forward to continued opportunities to work with you and the members of the subcommittee and Congress to enhance the impact that each bills will have on our ability to provide quality health care for our nation's veterans. I'll address a few key points for each bill today, and a more detailed explanation is in that written testimony. To be very clear up front, we do support the intent of each of these bills, and we will be committed to working with you to craft the best solution to meet those intents. I'll start with H.R. 1490, the Veterans Privacy Act. The bill concerns visual recording of veterans and procedures and is intended to ensure that such recordings are made only with the full and informed consent of the patient and his or her representative. VA supports the intent of H.R. 1492, but the believes that the bill could be improved so that it does not have unintended consequences that might impair our ability to provide state-of-the-art healthcare that is increasingly dependent on moving on technologies that connect patients and providers. Toward that end, we would recommend clarification of the term visual recording, and despite the 3 important exemptions carved out by the bill, the current definition still may have some ambiguity and as such could be open to interpretation. Such ambiguity could adversely impact patient care. For example, the term video recording could include certain x-rays, MRIs, and other clinical imaging studies such as catheterization that under a strict interpretation could be seen in a way that could prevent such images from being sent remotely, being secured channels for remote reading. VA has made great strides in our use of telehealth modalities to connect providers to patients and to other providers in ways that improve care across distance and time, and we believe clarification is needed to ensure that we don't stall the deployment or utilization of such technologies through unintended interpretations of the current language in the bill. We believe the wording of the bill could actually, in some respects, have the effect of lowering the current standard of care in that it would allow a doctor or psychologist to conduct imaging without the patient's consent if they deemed it medically necessary. And we are certain that this is not the intent of this legislation. So we fully agree with the intent and will work closely with you to ensure that the language is as precise and correct as possible. The second bill on the agenda is 1792. The Infectious Disease Reporting Act would require VA to report certain infectious diseases that occur in VA medical facilities as defined by each state and according to the laws of the state where the facility is located. The legislation authorizes states to file civil actions against VA and for payment of penalties. VA absolutely supports that its facilities report infectious diseases to external health authorities in a manner comparable to reporting done by non-VA healthcare facilities. VA understands the reporting of selected infectious diseases has been widely accepted as mutually advantageous to both healthcare providers and to the recipients of the information. Public reporting of designated infectious diseases is necessary to inform local, state, and federal health authorities about the current state of public health and about emerging threats, and therefore VA is committed to expanding and making more consistent its reporting to the appropriate state and local authorities in a more standardized basis for all reported diseases. We believe we can create the assurances and transparency that will result in reliable, consistent, and timely compliance with these requirements. We believe this effort would be more effective than requiring VA, which is a national health provider, to follow specific state law, and that would require a significant amount of administrative burden. But if the committee determines it prefers this approach of individual state mandates, we do have some technical suggestions on HR 1972, which are outlined in the written testimony. HR 1804, the Foreign Travel Accountability Act, establishes a requirement for semi-annual report of covered foreign travel. VA does not object to the idea of providing information to Congress and the taxpayers regarding its expenditures. However, VA does recommend that HR 1804 be amended as drafted. The requirements would be burdensome, especially in light of improvements made by VA on the amount extended foreign travel. We have exercised considerable restraint with regards to all travel, and to be specific, this has resulted in a 40% decline in the use of medical funding for foreign travel from FY11 to FY12. 25% of this is for covering out of U.S. operations like the clinic in the Philippines. So for speaking for VHA, we have worked hard to ensure that all travel, both domestic and foreign, is both essential and appropriately managed through federal travel system, which captures all the information needed to manage employee travel in a transactional manner. Thank you for the opportunity to testify before the committee, and I'd be pleased to respond to your questions or the members may have at this time.
Dr. Jesse, your testimony suggests VA encourages voluntary adherence to state-mandated processes. If VA is prepared to accept the administrative burden associated with voluntary adherence, why is it prepared to accept the burden of mandated adherence to state reporting requirements?
I'm sorry, I'm not sure I understood.
You know what, I think that is written. I'm sorry.
Can I answer what I think you're asking?
Well, okay. So, yeah, go ahead.
Okay, so I think VA does not have a problem with reporting to states. And in fact, the history is actually of us coming to you to ask for legislative relief to allow that to happen. Recent examples, as you would remember, are the reporting to the state prescribing councils that engages VA in the monitoring, particularly of opiate prescriptions, and before that to report to the state cancer registries. And so there's a lot of, there are privacy rights built into the Title 38 legislation that all have to be considered and I think readdressed to do this. So whether we do it, through legislation or whether we do it voluntarily, it's the burden is only that each state is different, and making sure that we do that in a state by state way creates it's complex, but we will do it. We have done it in the past. We've proven that we are committed to doing so.
Okay, so you're not opposed to it?
No.
Okay, just
not at
want
all.
to make sure. Okay, then, let's see, Dr. Jesse, in your testimony, VA states that H.R. 1792 would, quote, create administrative burdens by requiring compliance with many different state laws. I just think you answered that, so let's skip that one. Ms. Joyner, VA has indicated that it has a legal basis for covert visual recording in patient rooms. Can you please describe the department's purported legal authority in this regard?
Well, I think any analysis would have to start with the Fourth Amendment. The unlawful search and seizure. We'd look at the case law, which talks about the need for a particular search, the scope of the search, the manner in which the search would take place, and then, of course, the place of the search. I think my recommendation, if a facility wanted to do a covert observation, would also be to talk to the Assistant U.S. Attorney, just to discuss what was planned as well.
Okay. Mr. Miller.
So it begs the question, in the Tampa facility, was that procedure followed?
I'm not sure. I can find that out for you and give it to you for the record.
Okay, because it's been a year, and I would hope that since this apparently is the only incident of its type that's occurred within the system, and again, we want to work. I do want to work with VA to solve this problem, because obviously they felt there was a need, and I understand what the director says the need was, and so if you would take that for the record, I would appreciate it.
Ranking Member Kirkpatrick.
Thank you. Doctor, does HIPAA have an exemption for public health reporting where health staff is able to identify a person affected by a disease?
About HIPAA, though I do know that we can report I think the legislation that gets in the way is not HIPAA, it's ours. It's the 5701 and 1733, part of Title 38. I hope I said that correctly. But I'm not sure that HIPAA does, because these are requirements for managing patients, and generally one has a business relationship. There's a letter of a memorandum of understanding between the facilities and the state health departments that exist, and in fact those state health departments then it is the authority and that is MOUs of this with the state health authorities that the CDC comes in under when they come in as part of an investigation. So I'm not sure that HIPAA is the issue here, but you could probably answer that better.
As we said in the testimony, the real stumbling block is VA's own Title 38, and it's similar to the changes that Congress made with regard to, as Dr. Jesse said, the state prescription monitoring programs. So it's 5701 and it's 7332 of Title 38, and so changes to that would make the process of reporting easier.
Well, Doctor, I have a concern in your written testimony. You say there's a possibility that in reporting infectious diseases that personal information could be released, and so I just want to pursue that with you. How could that happen?
So I think the context of that was, and one of the reasons why we were so fastidious back on the reporting to the state cancer registries, because it turned out that some of those registries were in fact releasing patient-level information, and patients, VA patients, veterans, were being contacted by outside entities saying, we understand you have cancer and we would like to help you. And that release, as it turned out, was coming somehow through the state authority. So we need, in terms of protecting our patients, we need to make very certain that when we release data outside entities, that there are clear agreements about how that data will be managed and kept private and protected.
So that's going to require an MOU with all of these different agencies?
Yeah, generally it requires an MOU and with very specific statements about how data get handled, yes.
My other concern is the number of reports the VA has to make to Congress. Do you know how many of those reports are mandatory?
I have no idea.
Do you have any idea about the cost of that reporting?
I don't know about the cost, but I do know it requires extensive resources at times in order to compile information, particularly when that information is not retrievable out of an existing data set. So when we have to do things manually, it takes an incredible amount of time and an incredible amount of person hours to do that. And it just depends on how big the request is.
Can you get back to me with that information?
I can try, certainly, yeah.
And also, because now you're under the state reporting plan and the District of Columbia, so you have 51 reports you have to prepare. And are you advocating then for just one central reporting place so that you don't have to do all 51 states and the District of Columbia?
Yeah, that's a great question. I actually asked that myself because it would be easier for us. The CDC annually puts out a list of reportable diseases, and to my mind, it would seemingly be more straightforward to report directly to the CDC. But the answer that I got, and our infectious disease and public health people all agree with this, is that the public health knowledge base needs to be at the local level as quickly as possible. And so that's why it's been established that reporting comes through local and state authorities and then rolls up to the CDC, rather than going straight to the CDC and then going back down. It would be easier for us if we had an annual list from CDC of what needs to be reported and could report directly to them. The concern from the public health folk, including ours, is that bypassing the local authorities may actually create an asymmetry of information at their level where they need it most.
Okay. Thank you, Doctor. I yield back.
Mr. Huelskamp?
Thank you, Mr. Chairman. I want to follow up on a couple items. Dr. Jesse, you mentioned the incidents in where cancer patients had been solicited by outside companies. Were you able to determine exactly where they had received that information and with a certitude?
I don't remember the precise details, but we did know it had come through a release from one of the state boards. Now, whether that was voluntary or accidental, I don't know. But it certainly made redoubled our efforts and to get the appropriate legislative relief to allow that to happen.
Okay, I appreciate that. And as you recall, the committee had a hearing, I believe, 2 weeks ago about the VA database and 20 million veterans and personal medical information that was potentially hacked, and haven't seen many details of follow-up on that. One question I had at that hearing, which did not get answered, I don't know if I submitted it, was the follow-up that apparently the department provides credit monitoring services for those they believe whose information had been hacked. Do you know, and can you provide for the committee, I'm sure you can, how many folks that you provided and identified that needed that service?
I don't know about the hacking that you're referring to. I don't know about, because frankly, I can't say that we know who was. When we have a breach of information, and we've had, as you know, you get monthly reports on these, we do provide credit monitoring to people who we believe that their information, particularly Social Security numbers, have been compromised. And I'm sure we can tell you that. That's a matter of record, because I think we report that to you on a monthly basis. But I don't know in the incidents from the recent hearing and the talk about being hacked in, I just don't know.
Yeah, and you might, it was in quite a few of the local newspapers and made reference to that, and state-sponsored actors in the database, and information that was encrypted on the way out. And so, yeah, I'd like to see what those numbers of those you've identified as potentially having that problem. The second question would be, you do note in your testimony that H.R. 1792 would, quote, create administrative burdens by requiring compliance with many different state laws. As I understand, every private facility has to meet these requirements. And are you saying the VA should be exempt from these requirements when private facilities are not? I don't understand.
No, I think that actually comes back to the ranking member's question. Would the reporting on a national level through one central authority be easier and more straightforward? From a national level, we have to look across 50 states in the District of Columbia and maybe even some out of U.S. Areas of operation, Puerto Rico, Virgin Islands, Philippines, for instance. And all of those states have themselves individual regulations and methods of reporting. Now, the facilities in those states will know them, and in many cases are already complying with those state regulations. It's difficult to manage on our perspective because we've got to get these upfeeds from every individual facility. And one of the challenges as well is that, remember, the structure of the VA in terms of particularly the regional, the 1A medical centers that do the more complex things often pull from multiple states. So in VISN 6, which is Virginia, West Virginia, North Carolina, the patients seen in Richmond would be coming from other states on a regular basis. And then how does that information then get back to the state where the patient resides? And in that case, and so I've asked this question, and apparently that is something that the state health authorities would do on a point-to-point basis, but then it becomes kind of out of our hands. And so that from a single national reporting perspective, there may be some sense to that. But again, I'm told that reporting locally is probably the most important thing. And then entrusting the states, when they know the state of residence is different than the state of diagnosis, to get that information back.
Yeah, and I appreciate that difficulty, and I think it's becoming clear as we look at some of the proposed regulations out at HHS for the President's health care plan that would require, I believe, the VA to provide information to a national database in this hub, and then that's part of that. You're going to have to provide that for the hub already, is that correct?
We're going to provide it through these hubs, yes.
Yeah.
So
okay.
It's
how far along
are
you ready to implement that by January 1st as required under the law or not?
Well, I can't say for certain, but I would sure hope so.
Yeah, well, the law is pretty clear. There's no hope so. That's a requirement.
Well,
one other thing, for your superiors, I have 23 outstanding questions from early September that are based basic budget data, and they have yet to answer those questions. And it's pretty hard to hear you mention a monthly report that you're providing information when I have outstanding questions submitted through the committee that you all have refused to answer, Dr. Jesse. So you might ask your superiors in the budget division about that.
I will do that.
I yield back.
Thank you, Mr. Huelskamp. Mr. O'Rourke.
Thank you, Mr. Chairman. On the subject of infectious disease reporting,
Yes, sir.
for the veteran in the community that I represent in El Paso, Texas, if he wants to find out about a potential outbreak, for example, in the VA clinic in El Paso or one of the regional hospitals that serve that population there, how would he go about doing that? How is that information made available to the public and to the veterans that we serve?
So that question can be asked of the local facility, and every VA facility has an infection control nurse who has a tie to the National Infectious Disease Program, but it is the job of that person to keep track of all of the infections, both the ones, as you might guess, coming through the emergency department like flus, because these get reported up, as well as hospital-acquired infections, which, as I'm sure you all know, this healthcare system, the entire country is working hard to eliminate. But that information is available at the facility, and then when the reportable diseases go out, that can be gotten from the local health authorities as well, who will know by hospital who that is. I'm presuming that they release it by facility, but they do know it for the community. But the VA information is transparent. In fact, we report our hospital-acquired infections through a website run by HHS called Hospitals Compare. And the problem with that is that that data set, the HHS data set, is about 18 to 24 months in lags. So VA has a mirror site, which is called VA Hospitals Compare, where we report our data current and currently, and that is, both are publicly facing websites. And we also have a website called Aspire, and Aspire is named because we don't report how we are doing relative to other people. We report how we are doing relative to what the expected outcome, our expectations of the outcome should be. So, for instance, we don't believe it's sufficient to be in the top 10% of people in hospital-acquired infections. We believe they should be 0. And our reporting and how it appears in Aspire looks at that. So those are publicly facing websites. You can drill down to every facility, and they're available as well.
Great. And just to be clear, I think you touched on this, but what's the lag time between an outbreak and when that is reported on these publicly facing websites?
So the publicly reported go up monthly, I believe. It may be quarterly, but I believe it's monthly. But when you say an outbreak, when incidents, and so in public health terms, it's a difference between incidence and prevalence, meaning incidence is each individual event, and those should be reported as they occur. And then the prevalence is essentially what's there at the time, and so you're looking at two different things, and you need to be a little bit cautious of what you're looking at. So an outbreak would imply a cluster, the cluster of incidents in a period of time, as opposed to events that occur over a longer period of time where you're aggregating them.
Okay. And then I don't have the specific information that Chairman Miller was referring to in terms of covert surveillance within VA facilities, but wanted to know if you or Ms. Joyner could describe a scenario in which that would be appropriate. And I guess I'm mostly interested in being able to be responsive to veterans that I represent. Would that ever take place in the examination room, where I think someone could arguably have an expectation of privacy?
So the broad answer is it should not. Right. Now, there was a time when Joint Commission, I believe, and this does no longer exist, but there was a standard that said patients that were being monitored, meaning EKG monitoring in ICUs, should be in direct line of sight of the nursing station, and if not, they had to have video cameras to look at them. That no longer exists, but Joint Commission does have a standard that says if you are recording a patient, the patient has to be aware of it and sign consent on that. I cannot think of a incident where we would do covert surveillance as any matter of routine.
Or without a warrant?
Without a warrant,
in a place where someone has a reasonable expectation.
Yeah, without there, I just cannot come up with an instance where we would want to do that. Now, so an interesting thing is we do now having essentially a tele-ICU, and what happens in these is there is a control station that has physicians and intensivists and nurses. Literally one place can cover a broad geographic area, and all of those patients who are being remotely monitored, there is a camera in those rooms, that actually a very high fidelity camera that allows the physician in the remote site literally almost to do a physical exam.
But not covert.
But it's not covert, and people who are in those systems are well aware that this is an ICU space that is monitored by a tele-ICU operation, markedly improves patient safety. It's a great force multiplier for high-level intensivist care in places where we simply don't always have that standard. But it's not covert. And if you question about covert, I just can't imagine something that would not require a warrant.
Okay, thank you. Thank you, Mr. Chair.
Dr. Benishek.
Thank you, Mr. Chairman. Ms. Joyner, the VA raised a legal objection to the waiver of sovereign immunity in the bill because it would subject VA to the same civil penalties that would be imposed against other medical facilities in the state for failing to report. Why is that an unreasonable request?
I think it probably came down to the use of fiscal monies to be spending it to that rather than directly to patient care.
Well, it seems to me that sometimes there's, non-compliance, and we're just trying to think of a compliance motivator, I guess. Because I know in my experience, it seems sometimes that things don't just get done. I know Dr. Jesse and I have had conversations in the past about, the response to IG reports that don't get done. You know what I mean? You agree with the report, but and they say they're going to do it, and then it never happens, and nobody seems to be responsible. Those are the kind of issues that I think that are in the legislation trying to fix that. Dr. Jesse, do you have a comment on that?
Other than what Ms. Joyner said, I guess the one question is does that finding authority that the state health authorities or local health authorities have over the non-VA hospitals, how is it used often, and does it have an effect?
Yeah, I mean, everybody wants the money to be used for patient care. I mean, even the state facility, that would be fine. It's just, I think it's a method of compliance. I don't know exactly a better way of inducing compliance with regulations or the IG requests that we've seen in the past.
Well,
but I'm trying to
to
figure out a way of doing that.
The attention of this committee is a pretty good way to get.
Well, I know, but that
but
didn't seem to work in the sense of the issue that we brought up before with the the doctor plan within the VA, the IG report. There was 30 years of no plan with 8 IG reports, asking for a plan. So I still haven't seen, that plan. But I guess that's the best answer that I can get here today. Let me ask you another question, Dr. Can you explain what information is contained in the data submitted to the e-government travel service system? What kind of data is there?
So when in the what's called Fed Travel, or the electronic federal travel system, the first thing that has to go in there is actually, I guess, the equivalent of a travel order. So who is the traveler and where are they going and why? And then all of the travel arrangements get made through that. So you can see who flew where, what the cost of the flights were. It's in there. I don't think it captures hotels, but it captures it in terms of cost, because when the travelers submit their travel reimbursements, all the receipts get photocopied, get forwarded and sent somewhere. They're sent in. So you actually have a line-by-line accounting of the cost of the trip, and you have in there at the higher order of where the trip was to and for what purpose and who was the traveler.
And does that filled out by the traveler then, or the supervisor? Or?
So it has to be approved by a supervisor. Somebody has the approving authority for each person who travels. It's a supervisory function, and then the reports are filed on return of the trip, and then when they then get reviewed. So if I travel and then that gets submitted, it comes back and says it's under review. When it gets signed off, it'll then close it out, and then any out-of-pocket expenses that I had would then get reimbursed. So until that's signed off, it doesn't get reimbursed. Right. So we've worked very hard in VHA to ensure that Fed Traveler is used on a consistent basis for both domestic and foreign travel, and that way the information is captured as part of the transaction, as part of doing the work, and doesn't require somebody to go back pull paperwork, review things, and frankly have the opportunity to miss a lot. So it's having it done through this way, we think is important. One way or the other, it's important.
All right. Thank you. My time is up.
Mr. O'Rourke, do you have any further questions for this panel? Very well. Thank you all for your testimony, and then the panel's dismissed, and we are going to have to recess for votes.
Okay. Thank you.
I now welcome our third panel and final panel to the witness table. On this panel, we will hear from Dr. Timothy Jones, epidemiologist for the state of Tennessee and president of the Council of State and Territorial Epidemiologists, Mr. Nick McCormick, legislative associate for the Iraq and Afghanistan Veterans of America, and Dr. Paul Etkin, if I'm saying that right, Etkind, Senior Director of Infectious Diseases, National Association of County and City Health Officials. All of your complete written statements will be made part of the hearing record. Dr. Jones, you are now recognized for 5 minutes.
Good afternoon, Mr. Chairman, Ms. Kirkpatrick, and members of the subcommittee. As you've heard, I'm Tim Jones, the state epidemiologist in Tennessee, and I represent the Council for State and Territorial Epidemiologists, or CSTE. CSTE represents more than 1,100 members of the epidemiology and surveillance workforce in health departments who work on the front lines of public health to investigate and control communicable diseases. I'm pleased to offer this testimony on your legislation to strengthen infectious disease reporting by the U.S. Department of Veterans Affairs. 135 years of infectious disease reporting in the U.S. has culminated in the national diseases surveillance system that we use today. This surveillance system gives public health officials powerful capabilities to monitor the spread of diseases across the United States. As the voice of our nation's epidemiologists, CSTE is responsible for defining which diseases and conditions are reportable in states and which will be voluntarily reported to CDC. Effective public health surveillance begins with the local and state health departments. Mandatory disease reporting of individual patients is thus governed by state and local laws. A critical step in the ability to respond appropriately to outbreaks and other threats is the prompt notification of public health authorities on diseases posing a potential risk to our communities. Virtually all healthcare providers in all states are required to report communicable diseases to their local health authorities for additional investigation. Unfortunately, VA healthcare facilities do not always follow these rules, which has led to some substantial problems that may have been averted were this not the case. The outbreak of Legionnaire's disease associated with a VA hospital in Pennsylvania highlighted the importance of a prompt and thorough response to disease control. Unfortunately, it was not an isolated incident. I have personal experience with other examples of suboptimal coordination of disease reporting with VA institutions. I've been involved in investigations of known outbreaks in which the state health department's participation in a foodborne outbreak in a VA hospital was abruptly curtailed because of concerns about jurisdictional authorities. Lack of tuberculosis reporting has hampered control efforts outside a VA hospital. Failure to report an infection control lapse in a VA hospital made it very challenging for us to respond to inquiries from the community. We've learned indirectly and unofficially through personal acquaintances of a dramatic cluster of illnesses associated with preparation of medications in a healthcare institution, and it, unfortunately, resulted in several cases of blindness that may have been prevented with mandated reporting to public health authorities. To be clear, I don't mean to imply that I think that any of these examples reflect purposeful avoidance of responsibilities. To the contrary, I know that in many of these situations, well-meaning VA staff were as frustrated as we were about the effect of variable interpretations of the applicability of state health laws in these federal institutions. CSTE has reviewed the current versions of the VA reporting bills, and we're heartily supportive of your efforts. Federal legislation will enhance VA reporting to the national surveillance system and thus is in the best interest of public health. We feel strongly that it's best to craft legislation in such a way that mandates VA hospitals comply with state laws, which will ensure that they remain on equal footing with all healthcare facilities as these rules evolve over time. We believe that if VA facilities comply, many outbreaks will be detected, investigated, and stopped earlier than they may be otherwise. In addition, no patient of any healthcare institutions is a resident of an encapsulated universe. Patients, staff, and families are active members of the communities surrounding those facilities, and their inevitable interactions have important public health implications both inside and outside of those facilities. It's impossible to separate a healthcare facility from its community. Public health law must acknowledge this and facilitate and require VA healthcare facilities to follow the same laws that govern all other institutions in our states and which protect the health of us all. Thank you for the opportunity to testify today, and I'm happy to address your questions.
Mr. Mr. McCormick, you have 5 minutes to deliver your remarks.
Thank you, Mr. Chairman. Ranking Member Kirkpatrick, thank you for holding this important meeting this afternoon. On behalf of Iraq and Afghanistan Veterans of America, I would like to extend our gratitude for being given the opportunity to share with you our views and recommendations regarding these important pieces of legislation. IAVA is the nation's first and largest nonprofit, nonpartisan organization for veterans of the wars of Iraq and Afghanistan and their supporters. Founded in 2004, our mission is important but simple: to improve the lives of veterans and their families. With a steadily growing base of over 200,000 members and supporters, we strive to help create a society that honors and supports veterans of all generations. IAVA believes that effective oversight of veteran issues is integral to the successful implementation of policy and to the delivery of services that affect the lives of America's veteran population. The men and women who volunteer to serve in our nation's military enter into a unique agreement of trust with their government. This trust mandates persistent oversight of, and, when necessary, deliberate investigation into the agencies and mechanisms charged with delivery of services to this unique population. IAVA is, therefore, pleased to lend its support and endorsement of these 3 pieces of legislation pending before the committee. Regarding H.R. 1490, IAVA supports the Veterans Privacy Act, which would ensure that any visual recording made of a patient during the course of care through VA is conducted only with the consent of that patient or, in appropriate cases, a representative of the patient. There are undoubtedly certain circumstances that may warrant the installation of monitoring devices in patient rooms for the safety of both patients and staff, or to monitor a patient's behavioral activity, just as heart and respiration monitors are often needed to monitor a patient's physiological activity. However, IAVA believes that veterans and/or their family members who are receiving medical treatment at VA facilities or their representatives should be notified of the facility administration's intent, in consultation with the medical professionals directly involved in delivering care, to place cameras and/or other monitoring equipment in a patient's room, and no such action should be undertaken without the express consent of the patient or their representative. Regarding H.R. 1792, IAVA also supports the Infectious Disease Reporting Act, which would direct the Secretary of Veterans Affairs to report each case of reportable infectious disease that occurs at a medical facility of the VA to the appropriate state entity, as well as to the accrediting organization of such facility. Had this bill been law at the time of the outbreak of Legionnaire's disease at the O'Hare and Oakland campuses of the VA Pittsburgh healthcare system in 2011 and 2012, the number of infected people could potentially have been far lower. Indeed, the CDC's after-action report on this incident indicated that poor communication and procedural missteps in the VA Pittsburgh system were just as much to blame for the outbreak as the bacteria itself. Our veterans have been taught that the ability to communicate effectively is one of the most essential characteristics of good leadership and is necessary to mission success. IAVA fully supports the Infectious Disease Reporting Act because it represents the kind of common sense communication policy that American veterans deserve with regard to their health care. And finally, regarding H.R. 1804, IAVA also supports the Foreign Travel Accountability Act, which would direct the Secretary of Veterans Affairs to report semi-annually to the Congressional Veterans Committees on official foreign travel made by VA employees. These individuals are on the front lines of assisting American veterans and their family members with healthcare issues, educational benefits, and disability claims, and IAVA commends these employees for their work. However, according to VA reports produced to this committee, VA employees have taken over 1,300 trips for unspecified or unacceptably vague purposes. From the Internal Revenue Service to the General Services Administration, government spending scandals have become much too common an occurrence. The responsibility of the VA to support the nation's veterans necessitates that the VA be held to the highest ethical standards with regard to the management of public funds. Many of America's veterans and their families are experiencing great financial hardship while waiting for the disability claim to be processed, and many of them are waiting while they struggle to cope with the physical, emotional, and mental scars of war. IAVA supports the Foreign Travel Accountability Act because our veteran members, understand better than most that every penny counts and every penny should be accounted for. Mr. Chairman, we at IAVIA again appreciate the opportunity to offer our views on these important pieces of legislation, and we look forward to continuing to work with each of you, your staff, and the subcommittee to improve the lives of veterans and their families. Thank you again for your time and consideration.
Thank you, Mr. McCormick. Now, did you serve in Iraq or Afghanistan, or
I served in Iraq, Mr. Chairman, in 2008.
with what branch of service?
The U.S. Army, sir.
Thank you for your service. Dr. Edkind, you have 5 minutes. Thank you.
Thank you for this opportunity to speak with you today. My name is Paul Etkind. I'm Senior Director of Infectious Diseases at the National Association of County and City Health Officials, or NACCHO, and a former epidemiologist for the Massachusetts Health Department, as well as for the city of Nashua, New Hampshire. NACCHO is a membership organization comprised of the nation's 2,800 local health departments. The city, county, metropolitan, district, and tribal departments work every day to ensure the safety of the water we drink, the food we eat, the air we breathe, and to protect every resident from disease and disaster. Chairman Kaufman, NACCHO and local health departments across the country recognize and appreciate your leadership on this issue of disease reporting to federal, state, and local health authorities. NACCHO is pleased that the subcommittee is considering the Infectious Disease Reporting Act, or H.R. 1792. The bill directs the Secretary of Veterans Affairs to report each case of reportable infectious diseases that occurs at a medical facility of the Department of Veterans Affairs, or the VA, to the appropriate state entity as well as to the accrediting organization of such facility. The bill is an important step to ensuring coordination between state and local health departments and the VA healthcare facilities located within their jurisdictions. NACCHO believes it's critical for disease surveillance, identifying disease outbreaks, and recognizing disease trends in a community that reportable disease notices go to the health department of the county or the community where the person with this diagnosed disease or condition resides. Each state has its own legal mandates for what is reported and to whom, but there is a robust system of notification and referral between the states and between the states and their local health departments. Even if a VA facility is a regional reference institution that draws patients from different states and locales, this notification and referral system will assure that the right locale will be rapidly informed and prevention follow-up will be instituted. Although there are variances in the reporting conventions between some states, often the first responders to a notice of a reportable disease is at the local health department. The impact of prevention and control activities, which are the result of case investigations, are enhanced when cases are reported earlier. The VA is one of the largest medical care systems in our nation. Their facilities are an important part of the healthcare provider network in our nation's communities and are therefore important to public health surveillance as well as to disease prevention activities. In December 2012, NACCHO wrote the VA urging they reaffirm the importance of achieving timely and complete reporting of reportable diseases and conditions from all its healthcare facilities. Local health departments around the country have varying relationships with these facilities. Whether a VA reports notifiable disease to the health department should not be dependent upon individual relationships. Rather, it should be established as a system-wide expectation. Unfortunately, healthcare-associated infections, such as those that occurred at the Pittsburgh VA, are far too common. Since 2001, more than 150,000 patients have been potentially exposed to hepatitis B, hepatitis C, and HIV due to unsafe medical practices in American healthcare facilities. We believe this legislation is an important step to ensuring that possible healthcare-associated infections are reported and investigated as early as possible. The bill calls for penalties for non-reporting. In practice, penalties are rarely assessed for cases that are not reported. This puts the health department and the physician or medical facility into an adversarial position, which most health departments prefer not to do, since it may negatively affect future dealings between those entities. NACCHO recommends the VA health facility be subject to the same penalties as a medical facility not owned by the federal government. It keeps the option of a financial penalty open, but opens the institution up for other penalties or remediation strategies, which some states may have on their books. The bill has the added importance of facilitating the formal entrance of a large medical care facility system into the nation's public health surveillance and care system. NACHO has no doubt that this will be positive for disease prevention and will provide a formal mechanism for developing relationships between the VA at all levels and public health authorities at all levels. This will not only help with disease prevention, state or our nation might encounter. Chairman Kaufman and Ranking Member Kirkpatrick, thank you again for your attention to this important public health issue. NACHO looks forward to continuing to work with you to address this issue as the legislation moves forward. If you have questions about this statement, please don't hesitate to contact me, whether it's here or you have my email as well as my phone number. Thank you so much.
Thank you all for your testimony. First, Dr. Etkind, your organization, NACHO, just want to clarify this. It recommends amending the bill to require reporting diagnosed cases of infection rather than merely those occurring at a VA medical facility. That's right. We believe that the cases should be reported as they are diagnosed. If they're occurring at a medical center, it could be somebody who comes in with that, or it could be, it may not be a new infection. I think the clarity is greater if it's when the diagnosis is made, then it's considered to be a new case. Is this because of the time-sensitive nature in terms of public health of being able to respond and as a the sooner we know post-diagnosis, then the more effective we can be in terms of preventing other cases, whether they're community-based or helping the institution to prevent further cases. Okay. Dr. Jones, in your testimony, you mentioned your involvement in outbreaks at VA hospitals in which a state's health department participation was abruptly curtailed due to concerns about jurisdictional authorities. Can you elaborate on this a little further?
Yeah, that was an unfortunate example of, we knew that there was a gastroenteritis foodborne outbreak in a VA hospital. We had developed, it was reported to us, we had developed a questionnaire, we had a team there that had had their briefing sitting around the table in the facility, and we're just starting to go down to the hall to interview patients when someone came in and whispered into the ear of the infection control nurse, and he said, "I'm sorry, you're going to have to leave." And it was some invisible person's interpretation that all of a sudden the state did not have jurisdiction there.
Okay. Do you think under current law, were they right, though? Did the state have jurisdiction?
One of the problems is I think that there is, no, I mean, the VA's testimony says that VA doesn't have to comply.
Right.
I think there's a lot of crossed wires in terms of interpreting whether or not facilities have to comply depending on the institution and time.
Okay. Mr. McCormick, what are your thoughts on VA's recommendation that employee foreign travel paid for by non-federal sources be excluded from the foreign travel accountability ban?
I'm sorry, could you clarify that again, Mr. Chairman?
I'm assuming that by non-federal sources, so I suspect that would be, say, a nonprofit organization. I would assume that was involved in promoting something that the VA had an interest on internationally. And so they attended a conference that was underwritten by another entity that wasn't taxpayer funded. Would you feel that should fall under the accountability requirements as well?
I think, full accountability is a good thing, Mr. Chairman, and that's, more, in the military, 100% accountability is expected of every service member. And I think to hold those same standards and apply them to members of the VA is something that, we would be supportive of.
Okay. Ranking Member Kirkpatrick.
Thank you, Mr. Chairman. Dr. Etkind, how many VA facilities currently report infectious diseases?
I could not tell you that. I'm sorry. Again, there's no systematic um, collection of that information. It's all based on frankly, the personal relationships between the health authorities in those communities and the authorities within the VA.
Is there a standardized policy or system for reporting infectious diseases within the VA?
There is, my understanding is that there is a urging that reporting be done, but there is no mandate.
Here's my concern. You said that where there is mandatory reporting, it's rarely enforced. And so if we're requiring mandatory reporting by the VA and it's not enforced, then we really haven't made any progress here.
No, I would respectfully disagree. I think that we try to stay away from the mandate. If there's a problem, the typical response from local health departments, and frankly in my own history, has been to go and you discuss it, you find out where the disconnect is, and you try to remediate it. Is there a misunderstanding about some law? Is there a misunderstanding about regulations or procedures? And most often, a professional conversation between authorities is sufficient for making sure that everybody's on the same page.
I represent a large rural district in Arizona, and a lot of the veterans go to a private practice physician or a community health center or maybe a regional hospital that is not part of the VA system. Do you think this bill adequately covers those veterans who get treatment outside of the VA system?
I think that the private sector is clearly subject to the reporting laws of those states, Arizona in particular. So I don't fear that they're missed somehow. If there are cases that occur and it's discovered that they had not been reported, and perhaps we would have known about them much sooner, where we could have interrupted possible secondary transmission, at that point, that's when you visit the doctor and you talk about what happened and figure out where the disconnect is.
Dr. Jones, moving to you, one of our first hearings was about the Legionnaire outbreak, and you said in your testimony that you thought better coordination could have prevented some of the deaths and some of the cases that broke out of that. Can you describe for me in a little more detail what kind of coordination you see could have been in place at the VA to prevent those deaths?
I think in general, I mean, we in public health are used to investigating outbreaks quickly and thoroughly, and it's really important that that be done promptly before. I mean, the whole point is to stop it before it spreads. I was not in that particular VA, but we had an instance where a VA called us and said, we've had 4 patients with TB in the last 2 months. We think we've had a problem, and oh, by the way, 3 of them are dead. Had we known, how many people did they expose in the previous 2 months while we didn't know about them? And that's the kind of thing where I think in cooperation with the VA, they're taking good care of the patients, but we can help them do that tracing outside the VA in the community and prevent those kind of exposures if we hear about them promptly.
How quickly should they have been reported?
It depends on the disease, but basically for most things by the next business day. There are some things like meningitis where we want to get called at 3 a.m. on a Sunday because we've got to go to the school and find the other kids that were exposed and give them antibiotics. But in general, within a day or so.
Is it your opinion that the VA has a system in place right now for reporting infectious diseases that is adequate?
I think the system is not the problem at all. It's just following the law. But the VA has an incredibly advanced, sophisticated medical record system, and I think it would be resource-free for them. I mean, my understanding is someone could sit in Washington and hit a button at 8 p.m. every night and report to states. So I think it would be a very easy thing to implement.
Would it not also be easy to implement that reporting to the CDC?
Yes, in general, CDC does not like to collect personal identifiers, and they're really not the ones that contact patients individually and do the groundwork. So, collecting national data, yes, that would be easy, but I think It should not go through CDC and down to states because we don't have time to wait for that.
Okay, thank you, Doctor. I yield back.
Dr. Jones, can you talk a little about how different parts of the country face different challenges when it comes to infectious diseases?
Yes, we heard a little bit earlier about the fact that different states require different diseases to be reported. In essence, 99% of those lists are identical across the country. There are very rare exceptions. I mean, valley fever in Central California, Vibrio in coastal states where they have lots of oysters. But those are small exceptions. Never have I heard a complaint from a private or nonprofit hospital about administrative burden in terms of different rules in different places. I mean, it's essentially a non-issue because the states are so similar.
Okay. Dr. Etkind, in your testimony you state, quote, whether a VA reports notifiable diseases to the health department should not be dependent upon individual relationships. Can you talk about instances where the lack of personal relationships negatively impacted patients?
There's a delay in reporting, and ultimately, when the problem gets to be so great that you say, hey, we need to bring in other people, at that point, you're kind of far down the process, and you've lost opportunities to reduce the risk of people for further transmission.
And Mr. McCormick, have VA's actions of placing a covert camera in a veteran's room without consent and the Legionnaire's disease outbreak in Pittsburgh had any effect on veterans' trust in VA?
Mr. Chairman, I would certainly say it does. Obviously, given the number of issues that my organization has raised over the last few months and few years with respect to the VA, instances like these lead us to think that the VA's head is not in the game, so to speak, or their efforts at rectifying the problems that veterans face are misguided or, present us with a lot of problems that remain to be solved, and the path they choose on these issues is very troubling. So I would say, yes, the credibility definitely takes a hit when these sorts of things are in the news and so forth.
Thank you. Ranking Member Kirkpatrick.
Mr. McCormick, you were testifying about the Foreign Travel Accountability Act. In the act, we require a report to Congress semi-annually. Do you think that it would be better to have it just once a year rather than twice a year? I'd just like your opinion about that.
Simply in terms of numbers, Ranking Member Kirkpatrick, basically, I think semi-annually is better. Just it, cultivates sharper record keeping, and given the tight budgets here in DC today and so forth, I think it keeps individuals on their toes as far as the money that they're charged with handling, administering, and so forth. So I think semi-annually is far better.
And my last question is for anybody on the panel who can answer it. Doesn't HIPAA prevent the surveillance of a patient in a hospital, including the VA system?
Not at all. There is an exception for public health to receive personally identifiable information, and that's really the whole point. If someone's got TB, got HIV, whatever it happens to be, we need to know who they are, what their address is, to be able to go and find them, find their community members and their families, and do something about it. Public health has an impeccable record in terms of confidentiality, particularly in communicable diseases. I'm not aware of any breaches. And then any time that we share that information, absolutely, when it's not needed, we eliminate any personal identifiers. None go to CDC, none are ever public.
Okay, so you're satisfied that that's not happening?
Absolutely.
Okay. Thank you, panel. Thank you very much, and thank you, Mr. Chairman. I yield back.
Thank you, Ranking Member Kirkpatrick. And I just want to say that how important I think that this reporting is down at the state and local level from a public health standpoint, because you're the ones that are on the front lines of dealing with the infectious diseases, and I think it'd be highly inappropriate. I think it is highly inappropriate for the VA not to report to you, because your communities are impacted by, could be impacted or are impacted by the spread of infectious diseases when they go beyond the boundaries of the VA system, which is likely in infectious diseases. And I think, Mr. McCormick, I think you addressed the issue of non-federal travel, and I just want to state how important that is, because I think that they should have to disclose if they're not paying, if they're not traveling on the taxpayer's dime, who in fact is funding that, and is there a conflict of interest involved in that. And so I think it's just important to have a full accounting of that. And with that, the meeting's adjourned. Thank you very much.
Thank you, Mr. Chairman.
Thank you.
Have a good hearing.
Thanks. Very good.
We're doing this right here. So there's going to be a couple of minutes for pictures if you have a minute.
Oh, sure.
I think it's with us.
Okay.
It's that, so we get it done quickly.
Oh, no problem. Where do you want to go?
I think we're going to do them right now.
Oh. Oh, sitting? Okay. Okay. Get centered here.
Leave that one in there, so it looks good.
Yeah, you can leave that one here.
Here, you want to take a seat next to the Chairman Kaufman?
Oh.
I can stand, and
Here?
Harold's going to sit. Yeah.
Okay.